Thank you so much for the invitation to be here. You can probably tell that Dave and I spend a lot of time together through our through our work efforts. And he is one of many people across the federal government and a number of different agencies who are really committed to keep moving forward with finding ways to counteract the opioid epidemic. And I can't say in enough different ways to support what we really think, as Dave very eloquently said, the foundational issue behind the opioid epidemic, one of them at least, is to provide better pain management for people with chronic pain. If we can't do that, we are never going to get away from the opioid issues. So one effort, one of many efforts across the federal government that you've heard mentioned a number of times is the National Pain Strategy. As Dave mentioned, it came out about the same time that the CDC guideline came out and we tried in both of those reports to balance the need for more careful prescribing, integration of prescribing with other forms of care, but also the notion, and I think this was, ended up being highlighted in the CDC guideline, is interdisciplinary care has got to be there to provide the whole that taking away people's opioids are going to leave. So a little bit of detail on the National Pain Strategy, and then I'll jump over to a few other government efforts that you may not have heard too much about. So the National Pain Strategy is not the end-all, be-all to better pain management. But those who were committed to putting it together in a very careful way, I think meant it as a step-by-step set of deliverable and achievable objectives where we could move forward in advancing better pain care. So 5 years from now, which is sort of the extent of time that the objectives within the pain strategy were expected to take place, we're not going to have a perfect world of pain care, but we hope that there will have been a difference, partly from the pain strategy, partly from a number of different efforts, partly from an awareness that what we've got isn't working, and that, as Dr. Jonas said, we know there are other ways to approach pain care that are going to help out. So the National Pain Strategy is a multi-pronged approach to changing how we educate the public about pain, the stigma of pain, treatments that are available to pain, and so it's also a patient awareness of what treatments are available to them, where to go to look for it, what their options are. It also calls for professional education, and Dr. Siegel, you couldn't stress more the need for better education amongst providers, especially at the primary care level, and this is another one of 6 primary thematic areas of the National Pain Strategy. It also calls for a different pain strategy for care, and this is primarily outside of the military system in the public civilian system, where we pay on an intervention by intervention basis. We don't pay for coordinated, integrated care for people with persistent pain. And so changing the payer strategy depends first on understanding what we currently and how we currently pay for it, using an evidence base of what's better to move that payment strategy into a different realm, to pay for multidisciplinary care when it's needed. Another thing is how we get access to care. So we have people in cities where there are clinics, where there's good health care, who aren't getting the access that they need because of a number of different reasons. You go into rural areas and that situation becomes even worse. So delivering care, quality care is important, but getting access to a broader swath of the population is crucial. And that's a really tough challenge. The strategy is also looking at population research to understand the prevalence, the disability caused by pain, but the population research is one piece of the research called for in the National Pain Strategy. The evidence base for how we pay for pain care, how we deliver it, how we disseminate what we know is good pain care out into the population is a crucial piece of the National Pain Strategy. So where is the strategy at this point? The Office of the Assistant Secretary is taking the lead on the implementation effort. There is not a defined set-aside budget to do this, so the agencies that are involved in achieving the deliverables are expected to rise to the occasion, pull together the needed funds for the objectives which they have the greatest interest in or the greatest ability to move forward. So the implementation process is in its early stages, and we have a steering committee set up to get things moving. They've met several times. The work groups, which align with the themes that were outlined in the strategy report itself, are the same as those from the report. So there'll be a population research, there'll be a public awareness, there'll be an education. Dave's going to be in on this too. And so it's underway. We've had a little bit of a stall because of the transition in the administration, where some of the principals that we expected to be in on the effort, who are the leaders of the federal agencies involved in the opioid issues and the initiatives on pain, are no longer in place. So there's a little bit of a wait time to get everybody back in their spots and get them moving. We are planning on having a federal stakeholders partner meeting in May, and that meeting is intended for you, the community, to listen in, give us feedback on what we're doing right as far as the implementation strategy for the national pain strategy is going, and for us to provide an opportunity to tell you what we've done so far. So even though it's been quiet, and even though we've got a little bit of a pause going, there are a lot of things that are going on, and there's a lot of little positive steps that are happening. So we'll shortly be sending out information on where you can tune in. There'll be a webinar, there'll be a small room, so we'll have some people invited, but we really do want your feedback. It's tentatively scheduled for May 11th now. We've had some changes. So the research is crucial, and that's what NIH is all about. That's what several of our federal agencies are all about. And we've moved forward in a couple of areas as far as research that comes right out of the National Pain Strategy. The other really positive thing is last year in July, the Secretary of HHS released a research strategy along with a profile of what we're already doing for research to combat opioids, to come up with safer treatments, to manage pain better. And some of her objectives have been moving forward from the publication of that research strategy. So they really pushed to put 2016, 2017 funds into objectives of the National Pain Strategy, which is great. So a couple of things that came out of that, there's a pilot study that's being done to look at how we're paying for low back pain, what interventions we pay for at the public and private payer level, and then expanding that to a nationwide level. And given that, we'll know, what we shouldn't be paying for and what we should be moving towards paying for. We've got some pilot studies to incorporate electronic healthcare records data into better understanding pain prevalence, how it's used, the disability. That's attached to a large pragmatic trial that the NIH is funding, in part through a wonderful project that NCCIH has mentioned, has worked on. Dr. Jonas mentioned the center, in which Kaiser Healthcare System is taking clinics at the primary care level and randomizing them into integrated pain care and regular pain care that they would get from their primary care physician. So they're incorporating complementary approaches, chiropractic, acupuncture, massage, biopsychosocial approaches in general, and looking at how integrated care better benefits the patient and better benefits their costs. And so I think this could be a pivotal trial in that if a huge healthcare provider like Kaiser, if their data shows that it's a benefit to their patients and it benefits to them as far as cost analysis, that's a wonderful way to move integrated care forward. The evidence is there, the awareness is there, the dissemination, it's already in place. So one last thing I'd like to mention is we are now in filling in one missing piece of the national pain strategy through a federal pain research strategy, a long-term strategy for the NIH, the CDC, the FDA, all the federal agencies and departments, including the DoD and the VA, taking their pain portfolio and asking our experts in pain care, advocacy, research to tell us what do we really need to prioritize as far as pain research goes to get better evidence base, to make a difference for the patients to better understand pain. So we expect the public rollout of that final document on June 1st, and that will be through our annual National Pain Consortium Symposium. We expect to hold those two on the same day. So we should be able to release that. We have websites through NIH. If you just type in pain, you'll find them. So I think it's a wonderful time to really move integrated care forward. NIH is working with the VA and the DoD to really bring more evidence base for their integrated care programs into the military population. And as was mentioned, those public strategies are often the best way to move them out into the private sector. So again, thank you very much for being here. Most appreciate the invitation.